Thank you, Sri Priya. Good evening, all. So we have Ms. Jinny who will be taking the session for home-based care. She is working with Pallium India's staff nurse and has a total experience of 8 years in nursing field. She has undergone a certificate course in organ transplantation and psychiatric program as well. Over to you, Jinny. Welcome to the session.
Okay, thank you. Hi, good evening to you all. I hope you are all are doing well. Okay, now we are going to the section that home-based care. Are you ready for the session?
Yes.
Okay. Then first we'll discuss about the need of home care. Okay, can anybody say about the need of home care? What's the need of home care?
Home care is required because the patients can't come to the center or to the hospital. So teens have to go out. Often they are bedridden. Yeah.
Correct. Then who needs home care? Who is physically ill or unable to travel to the hospital? They need home care. And other one is there is nobody to bring the patient to the hospital. In that case, we should provide home care to the patient to give the proper health care. Okay. Then who is under financial crisis? So they don't have enough money to bring the patient to the hospital. In that case, we should provide home care. Then other one is in a road condition. You can see this picture, road is not proper. We have a lot of patients who is paralyzed. In this case, they can't bring the patient from the home to the hospital because they should carry the patient to the hospital. In that case, we should provide home care to the patient. Suppose patient is in catheter, they should change the catheter in each and every 3 to 4 weeks. So is it easy to bring the patient each 3 to 4 weeks to the hospital? No, I don't think so. It's easy to carry the patient from there to hospital. In that case, we should provide home care. Okay. These all are the important points we need to provide home care to the patients. Then we'll move on to the next topic. Components of home-based care. I know you all know about the palliative care. In palliative care, we have 4 aspects of the care that include both physical, emotional, social, and spiritual care. So first we'll discuss about the physical care. A 40-year-old man diagnosed with paraplegia. Patient is having Foley's catheter for incontinence of urine. Wife and 2 daughters. Wife, homemaker, eldest daughter 11 years and the younger daughter is 9-year-old. In this case, which type of care we need to give the patient?
Home care we can provide.
Yeah, we can provide home care because patient in Foley's catheter. So we need to change the catheter within 3 to 4 weeks. So they can't bring the patient to the hospital every time. So it would be better to provide home care. The palliative care that include physical care, emotional care, social care, and spiritual care. First, we'll discuss about the physical care. In physical care, first we should assess and treat the symptoms. When we go for the home care, we should assess the condition of the patient first, and according to that, we should treat the symptoms. Okay, if I'm going for the home care, patient is continuously vomiting and pain. We should treat pain and vomiting first. And after that, do the further assessment. Okay. Then next one is provision of physical aid. If patient is completely bedridden, or if patient can walk with the support, at that time we can provide walker or aid like bed, water bed or air mattress we can provide to prevent the bed sore and all. Then next main thing is follow-up. Follow-up is very important in home care setup. Otherwise, we can't know about the present condition of the patient. Then we'll move on to the emotional care. In emotional care, patient have fear, anxiety, suicidal thought, depression, guilt, loneliness, and feeling of being burdened to the family or loss of meaning in life. Can anyone guess that why they feel like that?
You can put your answers in the chat box as well.
Okay, if a patient is bedridden since long time, or he's suffering from any severe disease from long time, at that time he may have think about their future, like I would be burden to the family, or nobody is there to take care of me, or I means it's better to be die than this life. Okay, these type of thinking patient might have. So in this condition, what we can do? In this condition, what we can do? Can anyone say?
Maybe listen to them.
Yeah, correct. The first thing is listening. In this condition, we should listen. We should go and sit with the patient for some times. I know everyone are busy in their own life, but we should spend some time for them. Okay, we should go and sit with them, and we can talk with the patient, and we listen the patient peacefully. At that time, they can tell many things to us. So they can, at that time, we should try to explore the problems. So that we can give solution for their problems. These are the things which we are doing in emotional care. Okay. Then comes to the social care. If patient was the breadwinner of the family and he's become a bedridden since many days or many months, what will happen in their family?
Starvation will happen.
Yeah, correct.
So the
In this case, he can't go for any work, or he can't earn for the family, and he can't give proper education to the children, and in the society the status will be decreased. In this condition, we can provide some help for the patients. Like if patient is able to do work with their upper arms, we can provide some petty shops, and we can do some small scale industries like umbrella making or puppet making. Like that, we can do some help for the financial help for the family. But in case of completely ill patient, like bedridden patient, they can't do any work. So in that case, we'll give training for the primary caregiver. For example, if patient is male, he's totally bedridden. In that case, we can train his wife, like tailoring or some other works we can train to them. At that time, they can give care to the patient, and they can do the work at the same time. Okay, in this way, we can give social support to the patient. Then move on to the spiritual care. What do you mean by spiritual care? By name itself, we thought spiritual care is related to the religion. Actually, it's not related to the religion. In palliative care, spiritual care is not related to the religion. Actually, it's a thought of the patient, either the patient or the caregiver. The patient may have thought regarding why God did this to me, because I did not do any bad work, or I did not do anything to the to others. So why God did this to me, or caregiver also have the same thinking, like my mother is a very nice person, or she takes good care of us, or why did this happen to her. Okay, in this condition, as I mentioned before, which we are providing emotional care now, like that we can give care to the patient in this spiritual aspects. Okay, we can go and sit with the patient, and we can listen both the patient and caregiver individually. At that time we can understand what all are the thinking they have, and we can give proper solution for that also. This is regarding the spiritual care. Then we'll move on to the organizing home care services. How to organizing a home care service? For that, first we need a vehicle for traveling from our setups to the home care. That's very important. Then we need home care kit. Home care kit which include both medicines and procedure kit. Then trained volunteers are very important in this home care services. Then we need both trained doctors, nurses, and a physiotherapist, social officers. And after these things, we need a team meeting and discussion. After see each and every patient, we should come back to our setups and need a detailed meeting regarding the patient and discussion. At that time, we'll get many points from many sessions. At that time, we can choose the proper point and give proper care to the patient. Okay, the main and important thing is regular follow-up. Regular follow-up is very important in home care services, because if we are going for a patient to see at the first time, we'll start, for example, we'll start treatment for the pain. And if we come back and do the team meeting and everything, and we'll leave the patient like that, and then we don't get any idea about the further condition of the patient. Is the pain is decreased or pain is increased, or we don't know anything about the condition. So that we need a regular follow-up that can lead to a good quality of life. Okay. Then this is a home care kit which include both the procedure bags, medicine bags. Okay, you can see medicines in one bag and procedure trays and BP apparatus, everything in other bags. And we need to charts also.
If anybody has any queries till now,
Yeah, whether this will be provided with all volunteers, as these kits will be provided to the volunteers.
No. It's not provided to the volunteers. It should carry out from our team.
volunteers can help them, distribute the medicines. Maybe the prescription will be done by the doctors and the nurses. Maybe the volunteers can give it to the patients. That's how volunteers can help the team.
Okay.
And if the volunteers are trained for regular vitals, taking the BP and sugar and all, that can be done by volunteers. Prescriptions of medicines can be done by medical professionals only. Yes, Dr. Hassan.
Okay, thank you very much, madam. Can we please go to the previous slide of the where you said loss of money, loss of income, social care.
Yeah.
Social care.
Yes, ma'am. Yes, ma'am. Okay, before the spiritual, yeah. Okay, social care here, very nice. Like you have said, no job, no money, no food, loss of home, loss of land, no education, unable, no status of society stigma. May I please ask about the loss of relationship in the family members?
Sorry?
Loss of relation among the family.
Yeah, that is interpersonal relation. It's not coming into social.
Hello, am I audible?
Dr. Hassan. Yes, Dr. Hassan, you are very audible. Like, if I may interpret correctly, you want to know the impact of
Yes, I'm saying that.
The impact of a disease or any ailment or any such situation which impacts the
Yes,
relationship of the family, right?
Is your question like that, Dr. Hassan?
Yeah, when there is like home visit.
Okay, you want to know what
My question
role a
is,
volunteer
yes,
can
ma'am.
play?
My question is that when we go for. Yes, I'm saying that when the volunteer goes for the home visit, like they have to see about the job status, food, is he able to procure daily food, and the home status of the home, is it a good environment to look at, as you are saying, and loss of land, and then what about the family relation? The volunteer also intervenes to the family relation to us or not? That was my question, ma'am.
It is a very subjective thing, Dr. Hassan, if I could say so. Once a volunteer has established a rapport with the beneficiary, such that the beneficiary is feeling very open and very confident to share their relationship status or whatever is going on in their family life to the volunteer, yes, of course, we need to have a very active listening skill for that. But if the but if the beneficiary is choosing that no, I will not disclose after this much, we can never request or force them to share their relationship status. So it is a very subjective thing as far as sharing of their relationships inside the family is concerned. Sister Jinny, you would like to add something to that? What I said?
Actually, if we are going for first time, they don't have that much rapport with us. At the time, they don't need to, many of the patients are not able to talk with us deeply. If we are in that condition, if we are seeing the person first time, we don't try to open up with them. At the time, we can't identify the condition. Otherwise, the family matters with the in their deep family matters. So like that patient is also in first visit they couldn't. So we need to maintain a good rapport with them. At that time they start to open the condition, open the family issues with us. Then only we can do something for them. Otherwise we can't.
And as far as, even though I'm a very amateur in this, I believe that Sister Jinny, when it comes to the aspect of care, the relationship beneficiary maintains with his neighboring, immediate neighboring will come under social care, and the relationship inside the family, the immediate family will come under emotional care more.
Yeah, correct.
So there is that difference.
Thank you very much for your clarification. But why I mention it, because when we go, the volunteer goes in the home visit. So after listening to the challenges of the family, so when making the care plan for the social challenges, so to build up a team with the clinical, the home visit team, plus to help the patient at home, like the other days when the home visit is not there by the volunteer, who will support the patient. That's why it came to my mind, like in this social care aspect, like in this thing, why not the family members relation is included. Thank you very much.
Thank you. Thank you, Dr. Hassan. Thank you for the valid point. We'll look into that also. Like that's already there in the point. That is, so we'll move forward.
Yeah, then we'll move on to the type of home care. Do anyone know about the type of home care? What are the types of home care we have? We have DHC, NHC, SHC, and VHC. DHC means doctor home care, nurses home care, social worker home care, volunteer home care. Okay. Then in emotional support, as I mentioned before, communication with the patient is very important. without communication, we can't maintain a good rapport with the patient. So communication is very important. Then so that we can explore the problems of what they have. After exploring the problem, we can give a proper solution or we can fulfill the needs of the patient. So communication is very important in each and every home visits.
Yes, Miss Aishi, do you have anything?
Yeah, could you please get back to the previous slide?
Yes.
Yeah. Okay, okay. Thank you, thank you. I just wanted to clarify a few things. Thanks, thanks.
Okay, Aishi, strictly again this side. Regarding that, Vaishnu, may I ask you to go back to that slide, please? Okay, these are the basic types of home care wherein we differentiate the home cares by the person or the designation or the profile of the person who leads the team. For example, the DHC or the doctor-led home care is a team, is a multidisciplinary team where the doctor is the heading person. So, for example, the teams who are led by doctor, the beneficiaries will be having more medical aspects, if we may say so. And in cases where already the doctor had paid the visit and now only the supervisionary activities are needed or the regular catheter change, if we may so is required, then one of the experienced nurses might be leading the home care team. That is the NHC or the nurse-led home care team. Same goes with the social worker-led home care, where the beneficiary is reported to have a more of emotional support or social support. There, maybe the doctor or nurse will not be available, but the team will be led by the social worker. And of course, there is the volunteer-led home care team where the volunteer assigned for the particular area, he leads the team of the multidisciplinary professionals. Sister Jinny, you would like to add something in there before we move ahead?
Okay. Do you have any doubt with this doctor-led and nurse-led or social worker-led or otherwise volunteer-led home visit? If patient need a health care, means like if patient is very needy, in that case we should provide doctors, nurses, social worker, and each and every palliative care assistants. We all have a team, and we'll go to the patient and give treatment to the patient. But in case of unavailability of doctor, otherwise there is no that much need of the patient. We are regularly do the follow up to the patient. In that case, we are doing the nursing-led home care. But in case of patient is need more social support from outside, at that time maybe the doctor and nurses are not available. In that time, social workers led the home visit. So we provide the social worker home visit to the patient. But in case of volunteer-led home visit, the volunteers are main supportive team to the palliative care. So they are mainly go to the patients and identify the conditions, and they'll inform to us, this patient have this, these all are the symptoms, and there should be need of doctor or nurse. And this time we'll provide according to the volunteers report, we can go for the doctor or nurse visits. Okay.
I would like to add upon this, like as we know in Kerala, it's a community-based, community-based model that works in Kerala. So here, the need itself is, assessed by the volunteers. These volunteers will have an idea who, he or she will be knowing the area very nicely, that they'll be able to help the clinical team to understand who is the patient and what are his or her needs. So these volunteers will be generating these patients from the community, and then the team will be assessing the need again there. So in initial days, the first visit can be done by a doctor, and then a nurse, and then a social worker. So a basic team of home care includes a doctor, a nurse, and a social worker, but it's not necessary that every time all these people should be there for a home care. So that's what the basic point is for understanding. Yes, Dr. Hassan?
Thank you. Thank you very much for the clarification, Madam Supriya. Actually, I was trying to elaborate on this, like as Madam is presenter is saying the types of home care. So if we think on the palliative care models, like there are all of us here, we know that there are like different models, as Madam Supriya has mentioned: community palliative care, outpatient-based palliative care, inpatient-based palliative care, hospice. There's so many types of palliative care. So if it is community-based palliative care, most of the time the team is led by a nurse. And here in Lesotho, Africa, our the oncology clinic I work in, our team has home visit twice in a week, and the team is solely nurse-led, but also the team comprises of a psychology counselor, a social welfare officer, a nutritionist, and they always take information with the village health workers and some volunteers. There are very few here, the volunteers. That's why I was interested to join this training to know how your Palliam India thoughts I can also learn from you and implement it in our clinic. So thank you very much for this nice presentation.
Thank you so much, Dr. Hassan. So we'll move on.
Then we'll move on to the general hygiene, mainly in bedridden patients. Okay. In bedridden patients, we should ensure that client is getting daily bath, either daily bath or sponge bath. Patient is totally bedridden, we can't give bath daily. At that time, we can give sponge bath to the patient. Otherwise, we can provide daily bath to the patients. Okay. Then proper skincare is very important, and oral hygiene is also important. I know you all are know about the personal hygiene. Then we are doing skincare to prevent the bed sores. And oral hygiene is very important. Otherwise, it will cause to the oral thrush. It will leads to the infections and all. So these all are the main care which we should provide to the bedridden patients. Then move on to the bed sore. Can anyone tell me that what you mean by bed sore?
I mean, in this the bed sores happen with the constant laying in the bed. Some skin will be ruptured and it will become wounds. So that is for the bed sore.
Yeah. Okay. Bed sore.
When a patient is in bed for too long, then there can be some signs that can be seen, and if it's not taken care of.
Okay. And the bed sore, actually bed sore is happening because the prolonged pressure from the bony prominence to the tissues that will leads to the lack of blood supply or nutrition to the tissues. So their wound will start at that site, that will leads to the bed sore. Patient is prolonged bedridden. So they are not taking care of the skin, or they are not giving proper position to the patient. This condition, it may leads to the bed sore. If once the bed sore happen, we should give proper care to the patient. Otherwise, it will worse. Okay. So that we need to give general hygiene to the patient, like proper bed bath or sponge bath to the patient, and we should give proper dressing to the bed sore. And when we are doing the dressing to the bed sore, we should observe it's clean, or pus formation is there or not. Or skin care is very important in this case. We can use lubricants to give the skin care. Otherwise, if patient is prolonged in bed, they might chance to get rashes or tearing of the skin. If we are using lubricants like petroleum jelly, liquid paraffin, these type of lubricant we can use for the skin care. That will help the patient to prevent the tearing of the skin. Okay. Then
waterbeds will also provide also. Waterbed also will.
Yeah, waterbed. We can provide the aids like waterbed and airbed. We can provide, and we can provide the. We can change the position in each 2 hourly. Every 2 hours, we can change the position that can prevent the bed sore. And along with that, we can provide the nutritious, protein-rich food to the patient. That also give. And proper care is very important. Then
Hello.
Yes, sir. Tell me. Okay, that waterbed and airbed will comes under the comfort devices. Okay, if we can provide waterbed and airbed to the patient, that will help to reduce the compressions of the bony prominent areas. Okay, that will help to reduce the chances of bed sore. We can say if we are putting airbed to the patient, that completely prevent the bed sore, but we can prevent bed sore, but we should need to give position every 2 hourly. Then the main thing is follow-up care. Follow-up care is, as I mentioned before, follow-up care is very important in every home visits. In that, in case of bed sore also, we need to do a proper follow-up. Otherwise, we can't know the stages of the bed sore. Okay. Then we'll move on to the next topic. This is a picture of waterbed and airbed. Left side it's airbed and right side it's waterbed. Then move on to the oral hygiene. Do anyone identify the difference between first and second picture? What's the difference between first picture and second?
Occurring. The first one is not the bedridden patient, and second is the bedridden patient.
Yeah, first one is not a bedridden patient. The patient can sit with the support, and he can do the brushing with the help. So, but in case of second, he's bedridden, but he's conscious and oriented. So, in first case, we should provide the articles nearby him, and he needs an assistant to do the procedure. He's able to do, but he needs assistance. Okay. But in second case, he's totally bedridden like paraplegic. In that case, if patient is conscious and oriented, we can bring the patient to the corner of the bed, and we can provide the articles like kidney tray, brush, and we can do the oral care. Okay. In self-care education regarding the oral care, brush the teeth twice a day. Advise the patient or give the education to the caregiver to give a brush twice a day with a soft toothbrush. Toothpaste left in the mouth can cause dryness. So advise them to rinse the mouth clearly with warm saline water or soda bicarb solution. Otherwise, toothpaste can left in the mouth. It may lead to the dryness. And tongue to be brushed with soft toothbrush, and advise them to take plenty of water to prevent the dryness of the mouth. Then if patient is using dentures, advise them to remove at the night time. Okay, these all are the self-care education points we should teach the caregiver, either the caregiver or the patient. Then this is the oral hygiene for the terminally ill patient or totally bedridden who is not conscious and oriented. We'll show the video after this, and we can use sodium chloride solution for the oral cleaning. How to prepare the sodium chloride solution? Sodium chloride NS solution. I know you all know about the NS solution, which include 0.9% of sodium chloride. But in home care setups, every patient are not financially well, so they can't bring every time they can bring the NS solution. So we'll teach them how to prepare the NS solution in sodium chloride solution in their home settings. So that tell them to take 500 ml of water and add 1 teaspoon of normal salt and boil it well and allow to cool. And after that, they keep in a clean container for few days, and we can use that water for the oral cleaning. Okay. And instead of oral sodium saline, we can use soda bicarb solution also. In soda bicarb solution, in preparation of soda bicarb solution, we can use 500 ml of boiled water with 1/4 teaspoon of baking soda. Okay. there is no need to boil after adding the soda. We should take 500 of boiled water and add just 1/4 of the soda baker. These two solutions we are commonly using in oral care. Then we'll move on to a video. I hope you all understood regarding the oral care. Do you have any doubt? I think there is no doubt. So we'll move on to the catheter care. Okay.
Very important.
Yeah. For which type of patient we need to put the catheter? Yes, Saida.
Spoon should be wooden or the steel.
You can
That
use
spoon.
both the wooden and steel spoons according to the availability. It's better to use steel because wooden might have to broken.
Thank you.
Stella, ma'am.
Can I share something?
Yes, ma'am.
See, even if one more thing you can use is for the bedridden patients. You know the brush which we use, toothbrush. Okay,
Yes.
that toothbrush, the bristles just cut it off. And the same way they have wrapped it nicely with the gauze, you can use that. That way also you can use it. That's also very helpful.
Yes, ma'am. Yes. Thank you, ma'am, for the valid point.
Thank you. Welcome.
So I just had a question. So you
Yes,
you
sir.
say a toothbrush, you cut off the bristles,
Yeah.
and then you wrap it with gauze.
Yeah.
Is that what you said?
Yeah, that's what I said.
Okay. And that you dip it in salt water.
Yeah, same thing. Whatever rest she has said now, you can do it instead of spoon, you can use in this way also. And many of the centers, they do it in that way. When the patients are completely better and we have to give the oral care, they do it in that way also.
Okay. Okay. Thank you.
Welcome.
Okay, shall I move to the catheter care?
Sure, ma'am.
Yes, please.
Okay, in catheter care, the procedure will, care of the catheter will show the video. And before that, in that, we should observe for the catheter change. We should assess the timing of the catheter change. Normally, we are changing the catheter in 3 to 4 weeks, every 3 to 4 weeks. We have two types of catheter like Foley's catheter and silicone catheter. But in case of Foley's catheter, we need to change it within 3 to 4 weeks. But in silicone catheter, we can change it within 16 days because the silicone catheter is made with the tissue-friendly silicones, so that don't make any irritation to the patients. So we can put that till 16 days. Okay. So then the next thing we should observe is when we are putting the catheter, it should be a proper should maintain a proper aseptic technique. So otherwise it leads to the infections. Then perineal care is very important who are in catheter. So when we are going for the home care, we should educate the caregiver and patient regarding the perineal care. Because most of the patients have fear when they are doing the cleaning of that area, the catheter, there are chances to remove the catheter. So they don't touch that area, or they are not ready to clean that area. That leads to infection. So tell them that nothing will happen if you are doing the cleaning, because it has a balloon and it's fixed in the bladder. So if you are doing the proper cleaning of that area, that will not affect to the catheter. Okay. So advise them to do the proper perineal care. Then advise them to take more oral fluids. Otherwise, urinary infection, there are chances to get urinary infection. Fluid intake is very important. So don't forget to advise them to take more oral care. Either the means patient is in fluid restriction condition. At that time, we can't explain them to take more fluids. And other all conditions, we can tell the patient or either the caregiver to give more water to the patient. Then bowel care is very important. Do you have any idea about what's a bowel care is very important in catheter patient? What's the relation between bowel and the catheter? Okay, if the bladder and the bowel is parallel. So when patient is not passing motion regularly or passing motion correctly, or there is a constipation or something, that there is chance to compress the catheter or compress the bladder. So urine won't drain properly. So that may leads to the urinary infection. So who all are in catheter at that time, we should clearly observe for the bowel care also. Okay, he's having any constipation or something. First, we should treat for that, and after that, we'll give care to the catheter. Okay, these all regarding the catheter care, and we'll move on to the video. Yeah, understood regarding the catheter care, no? Do anyone have the doubts?
Yes, I had a doubt. The catheter care is to be administered only by a doctor, or can it be by a nurse?
Catheter can be administered by both the doctors and nurse. And catheter care, we should teach the caregivers. And we can do the catheter care as the first time. But in home care setups, we can't go and do the catheter care every day. So we should teach the caregivers how to do the catheter care, so they can do the catheter care properly every day.
Okay. Okay, thank you.
Okay. Yes, Dr. Hassan.
Thank you very much. I think one of our colleague participant, sir, just questioned about the catheter care. So actually, if we can be divided, like if it is a change of catheter or catheter care. If it is catheter care, then it can be done, as Madam Presenter is saying, by doctors, nurses, and even they can be taught to the caregivers. But if it is change of catheter, I think the ideal medical practice is it should be changed by the doctors and nurses. Because change of catheter, as we all know, that it goes inside the urethra and up to the bladder, if it is a urethral catheter. So it must be done by clinicians like nurses, and mostly nurses, and then if any complication arise, then doctors. Thank you very much.
Yeah, thank you, sir. Then we'll move on to the next topic. Ensuring drug compliance. Okay. In drug compliance, if in home care setups, we are providing the medicines to the patients. Okay. In hospital setups, there are nurses to administer the medicine to the patient. But in home care setups, we are giving the medicines to the either to the patient or the caregiver. So at that time, we should give the medicines with proper instructions. And we should label the medicines, like for what reason we are giving this medicine, and how frequently they should take the medicines. These things we should mention on the medicine cover, and inside that we can put the medicine and give to the patient, so that they won't confused to the medicines, how to take and what time they need to take, for what reason they have to take this medicine. Okay, this is very important. Then if we are going for the next visit, if in first visit we should provide medicine to the patient, and after the next visit we should check the number of medicines, which how much it's left, or they have medicine or not. If for example, if I'm going to give the medicine to the patient who is on tab paracetamol TDS, so for 1 month I need to give 90 tablets to the patient. Then after 1 month, in my next visit, I found 30 paracetamol remaining. So what it means? It means patient is not taking properly. Okay. It means a patient is not taking properly. So we should check the number of medicine in each and every visit. In that condition, we should again instruct the patient and caregiver and label the medicine again and instruct them, take the medicine in proper time. Then only we can control your symptoms or we can cure your disease. Then consider the financial status of the patient, in which if we are going for a home care, means many of the medicines we don't have. So in that condition, we are trying to prescribe the medicine. We are giving the prescription to the patient to buy the medicine. But many of the patient won't do that because due to the lack of money. So we think that, oh, they are being, might brought the medicine from outside and their condition is better. But actually, due to the lack of money, they won't. So in this condition, according to the financial status, only we should provide the prescription. Otherwise, in our setups, we are doing the refunding of the patient. If the patient is very from a very poor family, we if they are bring the medicines and we'll refund the bill of that patient. So whenever we prescribe the medicine in a home care setup, first we should assess the financial status. Then only we should prescribe a medicine. Okay.
There is a question in chat box. Can we use betadine solution for perineal care?
Yeah, sure. We can use betadine solution for the perineal care. We are commonly use betadine solution to clean the perineum, and after that we are using the 0.9% normal saline. In home care setups, as I thought before, as I mentioned before, you can use the homemade saline, like 500 ml of water with 1 teaspoon of salt. Betadine solution is not available in every home setups, no? At that time we can thought them that we can teach them that you can use the normal saline, homemade normal saline. But in hospital setups, we are commonly use betadine solution for the perineal care. Is it clear? Any doubt? Then what's the benefit of home visit? I need your points. What's the benefit of home visit?
You can unmute and yeah.
Security of the home and the added pressure of the hospital atmosphere is not there.
Okay. Then
we have 2 answers in chat: to make a rapport, to regular for regular follow-up, more personal care.
More medication and hygiene, reaching out of those who can't come to the hospital. Yeah, correct. Yeah, these all are the benefits which you people told me that these all are the benefits of the home care. In that, mainly the patient and family feel support, because most of the patient feel loneliness and they are isolated from the family due to the disease. So they feel somebody is there to support us. If we are going for the regular follow, they feel somebody support me or somebody is there to care me. So they feel very happy with our visit. So there is a main and important benefit for which we do the home visit. And the next one is patients receive individual attention. In hospital setups, we all are, I know you all know, in hospital settle, every nurses and doctors is very busy with each and every patient. So, but in home care setup, we can see only one patient at a time. So individual attention we can give to the patient. Okay. Then social isolation is less. For example, if patient has oral cancer, so they have wound on this area. So they are socially isolated. They don't want to come to the hospital because they are thinking that I have a wound. Everyone is observing me. So because of that, he's not ready to come for the hospital. So in this case, we can give the home care to the patient. At that time, social isolation. And if patient is socially isolated due to that, at that time we can go to them and we can speak with them. We can give the treatment to the patient. So he feels that yeah, somebody is there to care me. So he can't feel that much isolated. Okay. Then patient remains part of the family. If we are doing, if we are a team, that means we are a family. We are doing the home care to the family regularly. The patient should added in our family. So he should added in our, he'll become a family member of our family. And vice versa, we are also added their family also. Okay. If we are doing the home care regularly, we should be a member of their family. If in our setups, if we are going for a monthly visit, they know in which time period we'll visit them. So they'll wait for us, and they'll make some extra. In their home, there are many fruits, jackfruits, seasonal fruits would be there. At that time, they'll keep the fruits for us. They'll wait for us. This time period, they'll come. So this because they added us in their family. This is the next point. So then full assessment of the patient and family. In this case, in this home visit, we can assess both the patient and the family members. In palliative care, we are giving quality of life to both the patient and family members. So when we are going for the home visit, we can treat both the patient and the family members. But in hospital setup, patient is going for the hospital because everyone are busy. Doctors is also busy, so they can't treat both the patient and caregiver who is take the patient to the hospital. But in home care, we can do the care to the patient as well as the home as well as the primary caregiver also. Okay. Then understanding of family dynamics. If we are doing the regular visit to the family, we can understand the condition of the family. Means what's the condition, what are the family members in their family, means is they have any issues with the family members, or the parents, if parents is alone, means first time they won't ready to explain the condition, explain the problems which they have. But day by day, they can maintain a good rapport with us. At that time, they'll explore these all are the problems we have with my means with our children or our parents. So these all things we can understand by the regular home visit. And after that, prepare patient and family for any anticipated difficulties and symptoms. If they are struggling with any difficulties, so we can understand their situation and we can do the needs. We can fulfill their needs. Okay. As I mentioned before, if patient is socially isolated or he's not able to do any work and they can't earn for the family, so at that time we can give support to the patient, so that if we need to give support to the patient, we should know the detailed condition of the patient and family. So we need a detailed home visit. So home visit can help to give proper care and proper support to the family and the caregiver. These all are the benefits of home visit. Do you have any doubt? I hope you all understood, because no doubts from your side. Then in home care setups, teamwork is very important. What do you mean by team? Team means together everyone achieves more. That's a team. So In our home care setups, we need volunteers, social workers, doctors, nurses, physiotherapists, etc. And these are the teams which we have, and we are doing the home care for the patient. Our main aim is to cure sometimes, to relieve often, to comfort always. It's not how much we give, but how much love we put into giving. Okay. Thank you.
Thank you, Jinny, for this wonderful session. Hope everyone got the understanding of what is home care and why it is required. Any questions? Anybody so far? I think we have been discussing in between, so almost all the doubts are clear. So if anybody is left out, please raise your hands or unmute yourself and you can ask.
Any feedbacks or any experiences? If anyone in the group has already experience of home visits. Yes, Dr. Sureka.
Okay. How many days do you train volunteers? So at Palim India, for online trainings, these are the 5 days that we give for volunteer training program. But if it's an on-site training, we have 3 days training, 2 classroom trainings, and 1 day we send them to home care. So that's how the on-site training comes in. So all the sessions that are covered in this online sessions are covered in the on-site sessions also. So 2 days we'll go for classroom sessions. So 9 to 5 we'll have classroom sessions whole day, and 1 day we'll be sending them for home care. And next is
Evening, ma'am.
Yes.
Sureka here.
Yeah.
I have a doubt. Like, if you are going to train the volunteers, their education level will be different. Like comprehension,
Yes.
how much they can understand, what type of skills they can do. In common, every skill will be taught in the class.
Yes.
Like today's session and the on-site session. In computer.
Sorry, 1 second. Yeah.
Okay. So, how do you decide they are okay to send to the field visits? They're performing well. Do you have any assessment like how they are going to do and all after the training?
Like for on-site trainings, we when we send for home care, the first day will be the classroom session. Next day they'll be sent for home care, and the third day we'll have a feedback session with them. In the start of the second day will be third day will be a feedback by them, and then we'll be explaining them. The clinical part will be taken in the next day. That's how the on-site training happens. So first day we'll be explaining them about palliative care, the communication part, and what the activities of Palim India is. So that's what we cover in the first day. The second day we'll be sending them for home care. Third day we'll be taking the feedback, what they saw in the home care. And during the home care, we'll be giving them instructions that they will be an observer only. After that, the third day, we'll take the feedback from them, and then we'll be teaching them the clinical part. The session that we had today will be taken in the third day. And for volunteers who are regularly with us, we give them refresher trainings also. So whenever a volunteer is going for home care, our team also accompanies them. And we have told them that they like any interventions that they are making, they have to make a note of it, and they have to discuss with the clinical team and then move forward. So that's how the assessment part works. And we do
Okay,
have a
there will
feedback
be some
sessions.
more observation, and you'll be following them regularly.
Sorry?
Initially, it will be observership for them. Under the
Yes,
observership,
yes. Initially, it will be observership.
you will be
They'll be-
following them up. They will be
Yes.
in touch with you.
Yes.
Okay, thank you, ma'am.
Yeah. Okay, moving to the next question. In the social aspect, is it easy to provide job or training easily to become an earning member? Training. Actually, in social aspects, it's not that much easy to means provide something to the caregiver to make them an say earning member. So we should train them first. So, for example, if patient is hemiplegic, so he can do the things with their arms. In that condition, we can train them. What are the things we can do with the arms? So, for example, he can do the petty shops like small scale industries like small shops, vegetable shops, or he can make the umbrellas and puppet making. These things he can do with their his arms. So we should train them how to do these things, and from that thing they how to earn. First few days we can help them, and we can means make them how to sell it, or how to give this to outside to earn the money. In this condition we can train them. It's not easy as much as we are saying, but it's take time to become to make them as a money earner, or in that condition the main thing is training. So we have trained persons to train them how to do the things. So let me add to this. Like I'll set an example. Like I'll discuss an example that we have here in Palim, India. We have a patient who is paraplegic. He has gained experience in umbrella making, lotion making, soap making, and everything. And now he is the trainer of patients who come here. So that's how he has developed himself. So successful stories are also there. Yes, ma'am. Stella, ma'am.
Yeah, usually they set up a camp in the palliative care centers, and they invite the patients and their family. One person will be there. Otherwise, in some places it happens like the campus students helps on that days in the camps, because maybe the patient's family cannot come with the patient. They will have some other work at home. So what happens is the patient will be there, and the campus students helps them in helping them to make these things. So like what they said, there will be a trainer who will be teaching all these things to them, and that becomes earning for them. And initial time, usually the palliative care itself, they will help them to sell these things, and the profit goes to the patient. But as the days go by, they come to know how to sell it, and the profit they are going to take it. So this is some of the things. And if you would say, yeah, initial time it is little bit difficult, because to convince the patient family, convince the patient, it will be difficult. But if you try with the with your patients and families, they will come to understand, and they will start coming to your camps, and they will learn also these things. Yeah, someone like Sripriya has already done, but teamwork makes the dream work. Yeah, that is very true. It's all a teamwork. One person cannot do all these things. It's a teamwork.
Yes.
Thank you.
True. Thank you, ma'am. Okay. Next question is, what type of palliative care can be given to the family members of the patient? Actually, the meaning of the palliative care is to provide the quality of life to both the patient and the caregiver. So family members are included in our team or in our family. So if we are going to give the care to the patient, and that we can give both the emotional care and physical care to the family member also, who is taking care of the patient. If patient is admitted in our Palim India, in IP setups also, we are giving care to both the patient and the caregiver at the same time. Okay, if caregiver is not doing well, we are providing both the physical and emotional care to the caregiver and to the patient also. But and in case of
in case of family members, like their children are not able to go for the studies due to the lack of money, in our setups, we are providing the education support to the children also. So these all are the care which we can provide to the family members in palliative setups.
Moving on to the next question, is there any importance of Pampers for incontinence?
Do you mean the diapers?
Maybe, yeah, diapers.
Yeah. Actually, in incontinence, most of the patients are using diapers. But in palliative case care, we are because we have a lot of the patient from a poor family setups, so they can't money to buy a Pampers to use daily. And in that condition, we are if patient is male, we are suggested them to use condom catheter. And if they are able to do means bring the Pampers, so they can use. It's not restricted for the patient, but you should give skincare for the patients who are using Pampers. But in some cases, patient need Pampers, but they don't have money to buy that. We are providing the Pampers to the patients. But the main thing who is using Pampers is we should give health education regarding the skin care, because it may cause the rashes to the skin. So at that time, we should give proper skin care. Otherwise, it will cause means due to the incontinence, the skin would be more. It's due to the incontinence. There are chances to get infected or cause the tears of the skin.
So can I ask you something? So you would suggest to use a catheter that would be safer than using a pamper?
We have a lot of patients. According to the condition of the patient, we have suggested the catheter. Because for example, in case of prostate cancer, we can't suggest a catheter to that patient, because we don't know there is any obstruction or not. So at that time, we can't do that catheterization in home setups. So they might chances to bleed. So in that condition, we can't. So according to the condition, we can advise them catheterization or not. But if patient is able to avoid at that time, we are not advising catheter. But if patient is completely bedridden or paraplegic, in that case, few months we are put the patient on catheter, and after that we train the patient as well as the caregiver for the Nell cath drainage. So we bring the patient to the hospital, and we have a halfway home. Like we'll bring the patient and family to our hospital setups, that's halfway home, and we'll treat the patient for a few weeks or 3 to 4 weeks there, and we'll train the patient or caregiver. Patient is able to do the Nell cath drainage, we'll train him or her. Otherwise, the primary who is taking care of the patient, the primary caregiver, will give proper education to them how to do the Nell cath drainage. So and that will help them to reduce the infection. If patient is prolonged catheterized, it may leads to the infection. So the mainly we are doing, if patient need continuous catheterization, at that time we are giving the training of the Nell cath drainage.
So it's called Nell cath training. I'm sorry.
Yes.
Okay, moving to the next. Does the volunteer get any hands-on training with various groups like doctor, nurse, social worker? Any advanced training other than this online training? Like if you are interested to have a hands-on training, please get back to us with the details on when you can have it. We can send you for an observation visit here with our team, maybe based on the schedules that we have. We do have various training programs running in, so we'll have to figure it out how and when we can organize such a hands-on experience for you. So if you're interested, please let us know. We'll get back to you with the proper through proper channel and through proper scheduling and all. Okay. Do you have a feedback collection process? If yes, how many times in a year? Feedback collection process in the sense what? For the volunteers? Alina, can you be a little more specific about it? Alina, are you there? Or if you can just, maybe you can drop in a message. Yeah, yes, ma'am. Sorry, you are muted.
Yeah.
Yeah.
No, I was referring to the patients and caregivers. Do they need to fill up any kind of a feedback, whether they are happy with the services, if they have any kind of suggestions? Do you all
Yes.
have that system? And if
Yes,
you
yes.
do, how many times in a year? Would it be like once in a few months?
For inpatient, we have it for, once
No, I'm talking about the home-based care. Home-based.
For home-based, it's actually, if in home-based care, if we are going for the home care, if any feedback, they'll tell directly to us. Otherwise, they means most, if patient can mail to our mail ID at that time, they'll mail to directly to our institution.
Okay,
Otherwise,
okay.
these poor patients are tell directly to the team only.
Okay, fine.
We are
Thank you.
developing a feedback system actually. We are in progress. We don't have as such right now, but we are developing a system. So that's in progress.
All right. Thank you so much.
Thank you. Next, no. Okay. We don't have any questions. Yeah. In cases where the terminally ill patient passes away or dies, does the caregiving stop right there, or does the social worker continue to provide care for the family, at least for a while? Yeah, sure. In our setups, we have a bereavement call and bereavement visit. Bereavement call have to be done within 14 days of the passed away. Means when after the death, and bereavement visit. If we identify the condition of the caregiver is need for a bereavement visit after a bereavement call, we should provide a bereavement visit to the family, which include both the doctors, nurses, and social officers. We'll visit the patient and we'll identify the condition of the patient. We have many of the patient is we are providing the food kit. In that patient, means patient was the primary breadwinner, and when he dies, we'll go for the home visit and do the bereavement visit for the family, and we'll continue the care for further times. And when they are means the family members are ready to, means they are willing to make money. Otherwise, the children, we are providing help, education support also, and we are trained the primary caregiver to do some work, and till that time we'll give support, we'll provide support to the patient caregiver.
कहीं निकल रहा हो टाइट है
अरे भूल जाता है जब ये बनाते हैं.
Sorry. Okay. So we have a team to do the bereavement visit also. So we'll show the video after that for the bereavement visit. I think we don't have any questions, so we can move to the video that Jinny was talking about. Okay. That was the the process that we follow here at Pallium India. Hope everybody understood how bereavement visits and bereavement calls make a difference to the patients. Sorry, the caregivers. Any questions? I think everybody is in tears. I could, yeah. This was the same effect that we had here when we played this video to our team members. So we could understand.
It was more emotional.
Yeah.
More emotional aspect is there. It is
Yes.
other than we are putting to practical. It's happening to everybody. So we have to overcome this type of emotional aspects. I hope so.
Yes, yes. So thank you, Jinny, for this wonderful session. Thank you all for being attending the session also. Over to you, Shripriya.
Thank you, Sister Jinny. And thank you everyone for joining us on this wonderful evening. And before we sign off for the day, Eid Mubarak. Be with your family, be with your loved ones, and enjoy the weekends. And just a gentle reminder that we have one more session left, and we'll be going through that session on Monday. So till then, this is Shri Priya along with Sister Jinny and Ms. Sarati Venukumar signing off from the Tips Eco Hub. See you next Monday. Till then, everyone take care. Bye-bye.
Thank you. Thank you. Bye.